So today, thank you very much to Dr. Derek So. He kindly agreed to do this when I asked him. Dr. So was a member of the primary panel in the writing committee of the antiplatelet guidelines, which were recently published end of last year. And he's kindly agreed to give us an update on that. And I know this is an area of interest of research for Derek. So thank you so much for presenting today.
Thanks, Ellie. So I said one of the benefits, if you would, of being in the guidelines is that I get hassled every couple of years by Ellie every time a new guidelines come up to do a talk. But certainly I think having participated in it, it gives us much insight in terms of just antiplatelet care, but more importantly, seeing it from a clinician's eye. And my goal today is hopefully to make it easier in these muddy waters to clarify some concepts. So I was at I'm going to start off with this icebreaker. I was at an Orlando conference last week and I spotted this creature, and it's actually something that's quite commonly found in larger cities. It dwells in dark places, often has this nocturnal roaming pattern. It's been described as selfish in habits, and despite things going on, it doesn't listen to its other mammals in that class. So I'm going to come back to this at the very end. But the learning objective today is that we're going to discuss essentially the 7 main topics within the guidelines, talk about the evidence and the rationale behind it, and review through case scenarios and give some practical tips, especially on these areas of ambiguity. And then finally, to give a little insight in terms of other things that are coming down the pipeline. So when we talk about antiplatelet therapies, of course, there are multiple potential targets, but what we concentrated on within the guidelines is really aspirin and P2Y12 inhibitors. Okay. And hopefully from an audience point of view, the good thing about these guidelines is it really starts in the breadth of patients all the way from primary prevention right up to that chronic patient. But in between, we've got patients, of course, with ACS, patients who've had stents, patients with bypass surgery, patients with concurrent atrial fibrillation. So these are really applicable to all spectrum of cardiovascular specialists, primary care physicians, surgeons, no matter where you are in terms of your practice. I think it's important to recognize that when we're talking about the 2023 guidelines, all of this is predicated on the prior guidelines. So there's the 2018 guidelines, and some of the slides that I'm going to show is really to build up upon the 2018 guidelines. And this also was preceded by the 2012 guidelines, which again has some references in terms of that primary prevention bit. So I had the privilege of being both in the 2018 as well as the 2023 guidelines. And again, there are some changes, and I wanted to highlight this, and that partly constitutes sort of what I call the muddy waters. So these are some of the novelties in the 2023 guidelines. As usual, there were 2 co-chairs, but one of the things that CCS mandated this past year was that there are actually 2 methodologists that are assigned to all guidelines committee. And their job is to help collate the data, but at the same time, the intention was to actually create systematic reviews and also meta-analysis to really give the committee a full, broad picture in terms of the literature out there. As a group, we looked at 7 key topics. We started off with PICO questions. So each of us that are chairs of a section were given a PICO question. And the other thing that I highlighted in yellow, and this is really what muddies the water, if you would, is that we actually had this great pro software. And as a group, every time we met to talk about a topic, we actually had to go through a specific series of questions using these criteria and vote on it. And in order for something to become guidelines or have a recommendation, there has to be a 75% consensus. After this went to the secondary panel for further review. So the other thing, and I think this is really a unique and great aspect of all of this, is that Shamir Mehta, who is the prior chair of the last set of guidelines, certainly wanted really for us as a group to push this, which is that we wanted to give a Canadian context to all of this. And why is this important? Of course, is that there are already tons of other guidelines out there. So for us to put in the guidelines, we want to make sure that this is in the context of what's available in Canada, both looking at drugs, looking at costs, and something simple as prasugrel would be a great example, that certain doses of prasugrel is available in Europe and the US, but not here. or looking at timing of procedures. And some of the pros and tips that I'm going to go through today certainly encompasses sort of a Canadian spin and what is relevant to Canada. So there were 7 topics that we started off with. The first was aspirin and primary prevention. The second topic was specifically looking at DAP duration in patients with high bleeding risk. Number 3 was that age-old question, is there one P2Y12 inhibitor that's better than another in ACS patients? Number 4 was looking at DAP in medically treated ACS patients. Number 5, from an intervention point of view, is should we pre-treat patients prior to procedures and different types of procedure? 6 was specifically looking at bypass patients, both going into surgery and coming out of surgery in terms of what is that best antiplatelet therapy. And then finally, the last one was looking at that atrial fib patient and really building up upon what was present in 2018 to now. So I'm going to start off with this presentation, and we're going to go through 7 of them. So it's going to be a quick tour. So this is a 53-year-old gentleman, no cardiovascular disease in the past. Highlighted in red are a number of risk factors in this gentleman. And several risk scores were applied to this patient. And the summary of this is that this is a moderate to high risk patient in terms of primary prevention. So the question is there any evidence in terms of using aspirin as primary prevention, or can we actually hone in on specific subgroups that might benefit from this? So looking at this, and I'm going to run you through this, we're going to show a lot of these meta-analysis throughout this presentation, and this is what we did as a group. So looking at MACE for primary prevention with aspirin, what you see here is that there is a benefit overall of MACE reduction by primary prevention. And this certainly is very different from what was present in prior guidelines. Unfortunately, looking at the downside is that there also comes at a cost. There is an increase in major bleeding, as you see here. And more concerning is that there definitely is a significance in terms of intracranial bleed, be it a smaller risk. So the question is, how do we put all of this together? And as a guidelines committee, our final recommendation was this, that we would rule against the routine use regardless of subgroups, okay? And the reason is this, one of the things that really enticed us was, is there within these trials subgroups that might benefit? And we looked at everything from age to sex to people with diabetes, people with specific risk factors that we can actually put and apply a risk score. And unfortunately, looking at any of these subgroups, there's not a single subgroup where the benefits would outweigh the potential risk. And more importantly, because there's no mortality benefit to all of this, we weighed the MACE risk the same as any of these major bleeding risk. And this is one of the key diagrams in this section that I think might help should you encounter a patient where you're describing primary prevention. Okay. And this is summarizing all 3 of those meta-analyses together. So one simple way to put it is this. For every 1,000 patients that we're treating over 5 years, we reduce 4 cases of MACE, but we incur 5 cases of increased major bleeding. Okay. And I think selling that to a patient might be an easier way to put it. And certainly, I think a lot of it depends on what patients prefer in terms of outcomes, right? That if someone's very scared because every single family member of mine has dropped dead, and that I really want to prevent that MI, I'm not at a high bleeding risk, that might be a patient where you actually might apply an aspirin primary prevention. But again, the bottom line is this should not be routinely used in all patients. We did come up with some practical applications to this, and I'm going to go through a few of them. So again, as I showed you in that first slide, what about actually applying that Framingham risk? Can I actually choose a higher risk cohort that might benefit? And we would not recommend that because there's no evidence. The second scenario that comes up all the time here would be, what about that patient that for whatever reason gets a CT scan, finds coronary disease, but have absolutely no symptoms? Again, there is insufficient evidence to say that we would recommend routine primary prevention of aspirin in that patient. However, what we did come across, of course, is that other risk factor management, especially from a cholesterol standpoint, that would be a better use of that primary prevention for that specific patient cohort. So case number 2, an 81-year-old female has CKD, chronic anemia, and comes in with an inferior Stemi and has 1 stent. So for this patient, you see them at the 1-year Stemi clinic, which we all see our patients at 1 month. The question is, at that point, should you de-escalate to a single antiplatelet therapy, continue that DAP for 3 months, 6 months, or 12 months? Okay. So essentially in this section, the reason why this was applied was that this again was a build up to what we had from the 2018 guidelines. What you see on the right side here from the 2018 guidelines is that we did talk about people of high bleeding risk. And what we would suggest in that elective cohort is 1 month for 3 months and then go down to a single antiplatelet. And for the non-ST elevation patients, on that high-risk patient with bleeding on the right-hand side, is to, at that 1 year mark, then de-escalate. Okay. And since the 2018 guidelines, there's actually been a number of studies specifically looking at this high-risk bleeding population, so the HBR population. So what is an HBR population? And this is actually from the ARC definition. All the trials have some sort of permutation of these, but these are the aspects that basically gives you about a 4% chance of bleeding per year. And you need one major criteria on that green column here, or 2 minors on an orange to constitute as a high bleeding risk. Again, this is one of the main figures in the CJC paper of the guidelines. So putting the totality of the pooled evidence of all these studies that specifically looked at HBR population, so these could be a subset of a larger study, but all high bleeding risk patients, what you see up top is that there's no difference in MACE, but that there is that definite decrease in terms of major bleeding by truncating and coming with a short DAP regimen rather than the traditional long DAP regimen. The other thing that often comes up is if you're going to go down to a single antiplatelet, what is that antiplatelet? Should it be aspirin alone or P2Y12 alone? And some of us that participate in these studies, all of us are selfish in our ways, and we'd always say, I'm going to go over P2I12 because I want to protect the stent. But amazingly, about 50-50 in these studies went either to aspirin alone or P2I12 alone, and that there was no difference in terms of MACE between the two groups. So summarizing this, our group decided that the guideline recommendation would be this. In those patients with high bleeding risk, we would now shorten that DAP duration to 1 to 3 months only, after which, irrespective of whether it's an elective patient or an ACS patient, is to go to a single antiplatelet strategy. Okay, so that's the main recommendation. But within that, we did talk about, could we make a recommendation once you go to that single antiplatelet, should it be aspirin or should it be P2I12? And as I showed you before, when you look at the trials, there was no convincing way, signal one way or another, but most of us would say that we would go with a P2I12 alone. And I'm going to show you why that is in a second. Okay. But the other thing that we really were concerned about is that we don't want people doing this routinely without thinking of the patient. And one of the things that came up is this concept of complex anatomy or patient characteristics. And so another key diagram from the paper is what constitutes a complex PCI. And this encompasses everything from left main stenting to bifurcations, multiple stents in there, multi-vessel disease, more complex PCIs such as CTOs, when we actually rotablate or atherectomize the vessels, things that really would put us more caution in that patient, I might not de-escalate at that 3-month mark, even though that patient has a high bleeding risk. So what we did in this diagram was to actually summarize and really acquiesce what was brought up in 2018 and highlight these new findings. And those are in gray for both the ACS and elective patient. And that's really to highlight at that 1 to 3 month mark, de-escalate. And that de-escalation ideally should be a single antiplatelet. But one option is that if the patient is an ACS and they actually, let's say we're on aspirin and ticagrelor, is to de-escalate to aspirin and clopidogrel. So giving essentially that clinician lots of potential breadth in terms of how to choose the right therapy for the patient. There are a few, I think, practical tips that we should take into account. For sure, if you're going to have a high bleeding risk patients, we have to think both in the lab and outside of lab of strategies of how to avoid bleeding. Okay, for sure, radial access, avoid using 2B3As, and post-procedure, we should not be bridging these patients ideally. Avoid NSAIDs and always think PPI, something again that's often forgotten that we could use PPIs in conjunction with our DAP. I think the other thing worth mentioning, and we actually had a lot of discussion within the panel, is that these studies that were in that pooled analysis, a lot of them were using stent platforms that are actually not available in Canada or not routinely available in Canada. And a lot of what drove the outcomes was the Master DAB study, a platform that was not available in Canada. And the reason why we just want to highlight it is that on a workhorse stent, that's not definitively proven, okay? And certainly we do have sort of our higher premium stents available that have better evidence, but just to give you an idea, that's 4 times the price. And so I think that's worth thinking about and mentioning. And certainly there are really high bleeding risk patients, such as those going for liver transplant, where we might splurge and let's say go for the high-end stent. In BC, they were able to convince the government just to use high-end stents across the board. I think the other thing that I think would be worth mentioning is that a lot of these sections, when you actually read the document in totality, comes with this concept of shared decision-making. We really need to talk to our patients about pros and cons when we truncate and shorten that DAP duration. Okay. So why do we actually suggest going to a P2Y12 when you come off to a single antiplatelet agent? And this is really based on 2 things. This is a host exam study. So first of all, the disclaimer, host exam was not an HBR patient. So these are not high bleeding risk patients. These are patients that came off their DAP for that initial indication, be it at 6 months, 1 year, whatever their doctors have prescribed. And at that point, go to aspirin alone versus clopidogrel alone for that long-term therapy. What you see here is that there's an overall reduction in MACE, so a combination of MACE as well as major bleeding, but MACE by itself was reduced, and surprisingly, bleeding was also reduced. Okay, so a lot of us look at this and something doesn't quite make sense. Something that can actually reduce ischemic outcomes, why is it also reducing MACE? So definitely food for thought. The other thing that I think what warrants at least some thought is that this was 100% done in Asian populations. This was done in Korea. And one of the things that we know from Asian populations is that 40% of Asians have a under-responsiveness to clopidogrel. And because a lot of us carry a CYP2C19 loss of function allele, that basically decreases our ability to metabolize the clopidogrel. So again, something food for thought. The other basis in terms of why we would suggest a P2Y12 is this. This was a network meta-analysis that was done. And essentially, there weren't specific, outside of host exam, there weren't specific studies that would look at a P2Y12 alone versus that aspirin alone. But there were lots of studies that compare, let's say, adapt to a P2Y12, adapt to aspirin, and how to actually summarize all of this in the form of a network meta-analysis. So this is a complicated diagram, but actually, the more I look at it, the more I love it. Anything in green is good, anything in red is bad. And what you see here is putting the totality of the evidence that P2Y12 inhibitors by itself as monotherapy has the best profile in terms of decreasing both ischemic as well as bleeding outcomes. And the other thing that has always bugged most of us that are in the field is that when you look at DAP long term, even though it decreases MI as shown here, that it actually has this signal of decreasing overall death, so the all-cause death. Okay, so I think there are other practical considerations when we try and apply this, right? That in those HBR studies, STEMI patients were very few. And then the other thing is that if you're going to de-escalate someone because of a high bleeding risk, at that point, going for that monotherapy for a P2Y12, we probably should go clopidogrel alone rather than ticagrelor or prasugrel. Case number 3. So this is now a 71-year-old gentleman with a non-STEMI. And that question comes up is, what is that best P2Y12 agent? And this came because of the ISAR REACT trial. So ISAR REACT was a trial that sort of threw a grenade in terms of everything that what we thought or had biases towards. So they compared ticagrelor directly against prasugrel in non-STEMI patients. This was the basis of why the European guidelines actually changed to say that prasugrel would be preferred agent. Okay, and surprisingly, there's a reduction in MACE of prasugrel over ticagrelor without a cause of bleeding. Okay, again, people were concerned, why does something that decreases ischemic outcomes actually not increase bleeding? And there might be several reasons for this. So this is in a real world study. This was not drug company sponsored. This was physician initiated. But because of that, it was open label. And that once a day dosing versus twice a day dosing might have an impact, right, from a compliance point of view. And certainly one of the things that they saw within that study was that the discontinuation rate of either drug was much earlier than would be in a RCT, in a sponsored RCT. And then the other thing is that there was earlier discontinuation in that TIG group versus prazo group. Is it because of side effect profile? Is it compliance issues? And then the last thing is that there was a subset of that prazo group population that wasn't adjudicated from a bleeding point of view. So again, there are some things that would bother the panel based on that. So putting the pooled analysis, so ICER React 5 was the biggest of those studies, but there are a number of other studies. And looking at the totality, what you see here is that there's no overall advantage of ticagrelor over prasugrel or vice versa. So based on this, the guidelines committee suggested that either of those drugs, TIG or prasugrel, could be used in that ACS patient. Okay. Tasked with that committee was a second question that they had asked in a PICO question, which is there any evidence that if you're using ticagrelor or prasugrel to de-escalate and go down? So this would be the clinical scenario. So you've got someone that's got ticagrelor, they come and they said they're very short of breath. My bias, and that's not a bias, I think it's the right thing to do, is that if prasugrel is available, that patient should not be de-escalated, but should be switched. But if that patient's elderly, if that patient's had prior stroke, then prasugrel should not be your choice. And at that point, you might de-escalate. So there are several studies, and we pulled the two studies. And what you see here is that by doing that de-escalation, you actually decrease bleeding without a compromise from a MACE standpoint. So again, reassuring that that could be something to do. And again, putting the two sets of guidelines together, these are the two changes. Number one, in that standard 1 year, ticagrelor and prasugrel definitely would be the preferred choice over clopidogrel. And then that de-escalation piece that you could de-escalate and go from that more potent P2Y12 to aspirin and clopidogrel, as shown in gray here. But I do think that we need to, again, come back to that question. Why are you de-escalating? What is that rationale? Okay. If it's drug intolerance because you're shortness of breath, as I told you, that patient should not be de-escalated. They should be switched. The other thing is from a cost point of view, and this amazingly still has not trickled down to a lot of our clinicians. One of the residents came up to me and asked this the other day. So hopefully all of you by now know that ticagrelor and prasugrel are actually generic, and that there's a rule in Canada that as soon as a drug goes generic, it has to be a quarter of the original price. The only provinces that actually shut that out was New Brunswick. So New Brunswick still allows a higher price, but everywhere else it's actually a quarter of the original price. The other thing is to think about drug interactions, right? That if you've got a drug interaction, let's say if they're on anti-seizure medications and HIV medications, and you're originally on ticagrelor, that patient should be changed to a phenylpyridine. We already talked about the compliance issue. Once a day dosing versus twice a day dosing. For that patient that's already not taking their meds, it's probably a bad idea for them to go home with TIG. And then think about bleeding risk, right? We've talked a lot about bleeding risk. We've talked about complexity of PCI. These are all things that we need to take account when we actually think about de-escalating someone. Okay, so the fourth topic is illustrated by the 60-year-old male who comes in with a non-Stemi. Patient undergoes angiogram. There is coronary disease. There's actually a CT of a diagonal, but nothing enticing or indicated from a PCI point of view. So for that medically managed patient, is there good data in terms of the best choice of therapies? So this really came down to two sets of studies. On the left-hand side here is the prasugrel comparator, and this is done in a study called Trilogy ACS. So Trilogy ACS compared prasugrel against clopidogrel, and what it showed was that there's no difference in terms of MACE, but it comes at a cost of increased bleeding. And so because of that simple fact, the panel universally decided that clopidogrel should be over prasugrel if those are your two choices. On the right-hand side is what about ticagrelor versus clopidogrel? So this was all part of the original Plato study. But keeping in mind that Plato did not specifically have a separate study looking at that medically treated patient, unlike prasugrel. So these were patients that had ACS, got randomized at the start, went to the cath lab, did not have disease, and a post hoc look at that cohort, so that subset of patients, what they found was that this was consistent with the overall signal that ticagrelor has that advantage over clopidogrel. That's why this is in yellow, because it is weaker level of evidence, because this was a subgroup analysis. Okay, so the other question that got tasked with that subgroup is, what about the duration of therapy in that medically treated patient? And unfortunately, there is no specific study looking at that. And this comes based, and any evidence comes based on the Pegasus study. Okay, so because of this, we did not make a recommendation on that duration because there isn't strong enough evidence. But this is what happened in Pegasus. So Pegasus is any patients who have MIs, irrespective of whether they got stented, they could have had bypass surgery, but they got randomized to either that with ticagrelor and aspirin versus placebo. There was a 90 milligram as well as a 60 milligram dose. And what you see here is at that 3-year mark, there is that reduction in MACE as the primary outcome, but not surprisingly, did this come at a cost of bleeding. Okay, and so for that reason, some of those patients in that Pegasus cohort were medically treated, and so there is some evidence for up to 3 years. From a practical tip point of view, and we even knew this when we looked at the subgroup analysis from Pegasus, is that patients that benefit in Pegasus were type 1 MIs. So we cannot apply this, let's say, to type 2 MIs or Minoka patients or SCAD patients. Those patients, there is no evidence in terms of what that best antiplatelet therapy would be. The other thing that I think we have to think about in that selected patients, let's say lots of pulmonary disease, but just medically managed because there's nothing that's good for surgery or PCI, that patient we might think of extending and elongating that DAP duration. So number 5, this is a patient that is 79 years old, has permanent AF, and now comes in with a Stemi and comes out with 2 drug-eluting stent. Okay, so what is that best? Is it triple therapy? For how long? Is it aspirin and TIG, clopidogrel and the DOAC, prasugrel and the DOAC? Okay, so the topic here, of course, is atrial fibrillation. So there was talk of this in the 2018 guidelines, but at the time that we actually published the 2018 guidelines, when we wrote it, there was only one of those big 4 studies available. By the time we presented it at CCC, there were 2 studies available. So keeping that in mind, we needed to update that. And this is the totality of the pooled evidence, okay? So what you see here in that first panel is overall MACE, that there's no difference in terms of a dual pathway approach. So DOAC plus a P2Y12 versus a triple therapy inclusive of aspirin. No difference in terms of death, but C and D is where we actually need to take note of. D here is bleeding. By going to a dual pathway approach, of course, we decrease bleeding. However, and this is a big however, is that when you pull all the evidence together, there is an increased incidence in sternal stent thrombosis. Okay, so going back to the 2018 guidelines, what you see here, and I put both the elective PCI as well as those high-risk PCI or ACS patients, after stenting in patients with a concurrent indication for some sort of oral anticoagulation. And I'm going to draw your attention here specifically to the right-hand side. So these are CHAD 65, so indication for treatment from an AF point of view. We suggested that physicians can have up to 6 months, okay, to keep people on triple therapy before they go down to dual antiplatelet therapy. A dual pathway approach. But several studies have come since then, and the best study really to think about this was the Augustus study. So Augustus was unique in its design compared to the other big 3 DOAC studies in patients with concurrent PCIs. And what they did in Augustus was that they actually did a 2x2 factorial design. First of all, patients got randomized to apixaban versus VKA, so warfarin. And afterwards, there's a second randomization, which is aspirin versus a placebo. And the reason why this design is very good in terms of trying to really take a deeper dive into all of this is that it helps you clarify that what happens in each of those drugs separately versus their standard therapies. But at the same time, now we can actually look at all 4 groups separately, because by having that randomization, you've uniquely been able to have those 4 groups.
And when all of us sat down, when this was presented at the late breaking trial, one of the things that immediately came to light was this. In that aspirin versus placebo group, what you see here is that there is actually a doubling of stem thrombosis rates. Not statistically significant because these studies were powered purely to look at bleeding outcomes and not powered to look at ischemic outcomes. But from an interventionalist point of view, it definitely is concerning that you've got your double rate of stem thrombosis. Okay, so how can we actually take a deeper dive into this? A year after Augustus was actually presented at ACC, what they actually did was they actually did a specific analysis looking at when outcomes happen. And I'm going to show you two sets of drawings here, Kaplan-Meier curves. On the left-hand side here, what you see is 0 to 30 days. And by having that patient on aspirin, you actually reduce your MACE outcomes in that first 30 days. But after 30 days, those two curves are superimposed on each other, meaning that that highest risk of MACE where aspirin makes a difference is that first month. Bleeding, however, tells a different story. In green is your placebo, reduction in terms of bleeding outcomes in the first month. But after that first month and up until that 1 year mark, what you see is that those curves continue to diverge, meaning that bleeding keeps happening, but ischemic outcomes happen early. And so based on that, our recommendation is that you start off with your triple therapy at the time of PCI. It could be discontinued as early as 1 day, but that by 30 days, patients should be taken off their aspirin, really based on that Augustus sub-analysis. So what about after 12 months? So now you've got that patient, they've been on an OAC as well as their P2Y12, they're 1 year after their PCI. At that point, is there any evidence? And what we would suggest is going to an OAC monotherapy and stopping the P2Y12 or any antiplatelets. And the reason is this is based on 2 studies. And what you see here is that by going on an OAC alone, there's no cost or pace in terms of increasing MACE, but you have that advantage of decreasing bleeding. Putting all of this together, this mean diagram from this section really summarizes it all, that at up to 30 days, aspirin should come off, but what we would suggest from P2Y12 therapy alone is that that patient now should be on clopidogrel. So why is that case? And I remember actually thinking about this a long time ago, and I actually went and counted by hand how many patients were on ticagrelor and prasugrel. There are about 500 and change in terms of patients that are on TIG or on prasugrel in these studies. So definitely not enough evidence when you look at these. Anywhere from 88 to 95% of these patients in these potent on the studies that were looking at this question were on clopidogrel. And the other thing is, if we are doing this to decrease bleeding risk, you probably should take the drug that has the lowest bleeding profile, and that would be clopidogrel. So scenario number 6, a 50-year-old from Cornwall comes in with a non-Stemi. And now this is Friday afternoon, triage form gets sent to our triage office, but realistically, because the patient's stable, we would not be shipping that patient from Cornwall to here. So the earliest would be Monday. So is there evidence for pretreatment? Okay, and so we actually broke this down into 3 separate cohorts: a STEMI cohort, a non-STEMI cohort, and that stable coronary disease, really to take a deeper dive in terms of, for those scenarios, what would be the best. I'm going to start off with the easiest one, which is STEMI. So this is illustrated by the Atlantic study, but there are actually a number of other studies. So we did do a pool analysis, but the pool analysis came up with the exact conclusions of the Atlantic study, which is by having pre-treatment or no pre-treatment with ticagrelor in the STEMI population, what you see is that there's no difference in MACE, no difference in bleeding, but there is that decrease in stem thrombosis by pre-treating patients with a potent P2Y12 agent. Okay, so based on that, the STEMI recommendation is yes to that pre-treatment. Now, moving on to non-STEMI, this was based on 2 studies. First of all, this is a co-study by Montelesco, and what they did was pre-treat versus no pre-treat in prasugrel patients that are going to the lab. And what they found is that by having a pre-treatment, you actually incur increased bleeding. But when you look at the ischemic MACE outcome, those curves are superimposed, no difference between pre-treating and no pre-treatment. The other was looking at ticagrelor, and this is a dubious study. And essentially what they did was essentially look at a NACE and no difference in terms of pre-treatment with ticagrelor versus no pre-treatment. Okay. Putting these two together, though, one interesting fact came out. And now what it says is that in these studies, the median time in terms of arrival to the cath lab was 23.3 hours, and they're bang on the same between the two studies, okay? So definitely that's something to take into context. And breaking that back into the Canadian front, and that's why I started with that Cornwall patient. Realistically, most of us know that that Cornwall patient unlikely going to be in the cath lab earlier than 48, 72 hours at the very earliest. And this is actually back to that original cure study years ago done out of Hamilton by Shamir Mehta. And what you see, having that clopidogrel pre-treatment before PCI in ACS patients, as early as 24 hours, there was already benefits, and those benefits were sustained up to 30 days and even up to 12 months. So based on that, our recommendation is this. We would vote against routine pre-treatment in those patients that could get to the cath lab quicker than 24 hours. But if there's a delay of greater than 24 hours, we do suggest routine treatment. Okay. Last group is that stable patient. So the stable patient comes in through our day unit. Should we be pre-treating? There are 3 RCTs. Overall, no difference in MACE and no difference in bleeding. Okay, so no good evidence to say that we should pre-treat this patient. And then this scenario comes up all the time. My fellow looks over at me. We forgot to give clopidogrel pre-bolus. This patient's on our table. Should we just give a dose of TIG? It's going to kick in quicker. We're going to be able to do our PCI. And the problem is this. So this was actually studied in the Alpheus study. And there's no reduction in terms of periprocedural MI, but there is the signal of an increased bleeding at 30 days. Okay, so for that reason, again, I'm not a big fan of this, but I know my colleagues, some of them, that's their routine. But the guidelines would suggest routine pre-treatment in the elective patient. Okay. One other thing, if you're going to break that rule and actually start off and give your dose of ticagrelor, remember that ticagrelor, unlike prasugrel and clopidogrel, work on a different pathway. It's a direct inhibitor of a P2Y12 receptor. But because now you're crossing to a final pyridine, if you're going to do the crossover, you need to rebolus that patient unless they've got a high bleeding risk. And this is actually from the 2018 guidelines that we wrote a section specifically on how to change people's therapies. So putting that all together, again, STEMI, pre-bolus, non-STEMI, less than 24 hours don't, greater than 24 hours, go ahead. And then stable coronary disease, no good evidence to say specifically do it. There are several practical tips, and I'm just going to highlight 2 of them. If you've got a pre-planned PCI on that elective basis, that patient should have pre-treatment 2 hours beforehand. And then this is a big one, right? We often see these ugly ECGs, and we tell our minds this is going to be a bad triple vessel or a left main. And yet we routinely knee-jerk response, boom, ticagrelor goes in. So the guideline committee actually would suggest that pre-treatment would not be indicated. And even if there was a 24-hour delay, use other antithrombotics and do not give a P2Y12. If you really had to give a P2Y12, I would suggest clopidogrel. Do not give your dose of TIG or prasugrel in that patient. So finally, scenario number 7 is patients going to bypass surgery. So this is a 74-year-old with surgical disease after coming in with a non-STEMI. Unfortunately, patient was pre-treated with ticagrelor. So now what do you do? Do we wait? How long do we wait for? And what do we do? And similarly, can that evidence be applied to that clopidogrel patients? So peri-op, long-term, okay? So within this group, we actually look, first of all, at ticagrelor and clopidogrel separately. And what the original 2018 guidelines was wait 5 to 7 days. But with accumulating evidence, and now there's been a number of large cohort studies that have looked at this. And within here in Montreal, we actually carried out the rapid CABG study. And a rapid CABG, be it a smaller study, randomized patients to going day 2, day 3 versus going 5 to 7 days. And what you see is that there's no difference in terms of periprocedural bleeding on that early approach versus the delayed approach. There is a reduction in terms of hospital stay. There is numerically actually an advantage of going early to decrease ischemic outcomes, but this was a very small study, so we just need to have that as a hypothesis generating aspect of it. Okay. So in clopidogrel, though, there's only been one very, very small RCT of 40 and change patients, so very hard to make that definitive suggestion. But as a guidelines committee, what we thought was this, that there should be clopidogrel discontinuation and going anywhere between day 2 to 7, but we have to take into account the anatomy, the stability of the patient, and surgical expertise and comfort of taking that patient early. And those are things to think about. So based on that, that updated recommendation is really on that ticagrelor front, where we've moved from 5 to 7 days to 2 to 3 days. And that is based on rapid CABG and a number of other cohort studies. So what about that ACS patients or any patients who have after bypass surgery? Is DAP after bypass surgery better than single antiplatelet therapy? And the recommendation overall is that DAP should be used over a single antiplatelet. And I'm going to show you some of those meta-analysis curves in a second. But specifically in that ACS cohort, that it should be a more potent P2Y12, so ticagrelor or prasugrel over clopidogrel. So why is that the case? So this is another study that came out of Ottawa. And what we actually did was we actually looked at the totality of evidence on ACS patients that either had a more potent versus a less potent antiplatelet strategy. And amazingly, when you actually look at mortality, so this is mortality, that there's a mortality benefit when you only look at the RCTs, that mortality is reduced when you take a more potent antiplatelet approach. And this constitutes even back to the 2B3A days, all the way to the ticagrelor as well as prasugrel evidence. Okay, so it's something that's intriguing, but we don't know exactly why. And within the Trident study that looked at prasugrel, or Plato that looked at ticagrelor, these patients weren't slated to go to surgery. It just happens these were ACS patients that went on to surgery, but there were enough patients that when you look at each study separately, same thing. There is a mortality benefit of prasugrel over clopidogrel, ticagrelor over clopidogrel. Okay, so looking at the majority of these pooled analysis, the specific questions that they were looking at in post-bypass stage patients was graft patency. And what you see here is taking a DAP, you improve graft patency. And based on these are the recommendations. In ACS patients, okay, DAP over single antiplatelet, realizing that in on-pump patient, what you get is patency of your grafts. But intriguingly, in off-pump patients, there is the signal of actually a reduction in MACE, okay? Similarly, even in that elective patient, we did discern between the difference between that on-pump versus off-pump simply because of the outcomes here. And the difference here is clopidogrel, of course, in that elective, but in that ACS patient would be a more potent P2Y12, okay? So I think summarizing all those together, there are a few things I wanted to end with. So there are ongoing controversies and concerns, and certainly I'm sure a lot of my PCI colleagues, and I'm sure a lot of the surgical colleagues can debate some of these controversies and concerns. So remember that in the last set of guidelines, we did mention a compass-like approach, so a dual pathway approach on that long-term basis. So how does that compare with, let's say, a single antiplatelet approach with P2Y12 alone or an aspirin and alone? We don't really have that definitive therapy. And especially for that patient who we come up and say that single antiplatelet is the best choice, we're discontinuing it early. But if we discontinue it early for high bleeding risk, what truly should be that P2Y12? The other thing to keep in mind, and this is probably a problem with a lot of cardiology study, is that the totality of the evidence, most of these are male patients. So we don't know in terms of female patients. And there are actually several US studies right now that are specifically geared towards females only or minority only to really try and improve the level of evidence there. A lot of these shortened DAP regimens come out of Asia, so out of Japan, out of Korea. And as I told you before, there is this concern in terms of the differences in genetics within an Asian population, that it's interesting, even though that genetic variant is at up to 40%, that overall there is this Asian paradox. For whatever reasons, Asians do not get as many stem thrombosis events as non-Asians. So bypass. Remember I told you about Trident and Plato. They stuck onto whatever they were randomized to pre-bypass surgery. There was no separate randomization. And this is one of the things that a few of us would push back. Can we actually now mount specifically clopidogrel versus ticagrelor, clopidogrel versus prasugrel afterwards in that bypass population? The other thing that comes up is this, and this I never even thought about until I was at a recent conference. Someone asked this question: if you're going to suggest going to a P2Y12 alone strategy, that patient subsequently gets admitted to hospital for non-cardiac surgery, and now they're going into cardiac surgery. Should you stop the P2Y12 and cross them over to aspirin before? Is there benefits there? Don't know. Okay. And finally, this is something that I think is a practical aspect, right? I go into clinic every day. 40% of my patients, right, do not have a GP. Is it responsible for us to say P2Y12 indefinitely and we're not seeing that patient? Are we now obligated to see that patient yearly? And that patient stopping the P2Y12 because their prescription runs out versus aspirin alone. And I think ISO React 5 really brings to that question, right? In a real life setting, it's very easy for us to sit in our ivory towers and say, this is the thing to do based on evidence. But on a real life basis, it might be a very different outcome. So other things, genetics and phenotyping, as you know, that's a lot of my prior research. There's actually a separate guidelines international. We don't call ourselves a guidelines committee, but we've got a consensus statement consisting of international experts. So we wrote one set of recommendations based on genetics and phenotyping a few years ago. We're actually doing a second iteration of these consensus statement this year. So more to come in this coming year, maybe another invite back for ranks. So summarizing all of this, I think the three main take homes to this. We have to think about that high bleeding risk patient and think about the concept of actually truncating our DAP duration. We have to think about complexity of our patient characteristics, right? What is that high risk patient, be it anatomy, be it PCI, but we need to think carefully. And irrespective of all the way from that primary prevention bit all the way to that surgery patient, we have to think about it from a patient point of view, right? What are patient preferences? What are you most scared of? What are things that would actually change the quality of life? And those are things that we have to take into account as clinicians. So I started with this question about this creature in Orlando. And of course, this creature that I was referring to are interventionalists, and I could put surgeons in that same category. I was hoping a few of my surgical colleagues. And I think all of us, of course, we work a lot at nighttime, but we're quite set in our ways. And as you come across, we've got some strong characters, people are biased, right? So when you look at a lot of these PCI trials, not every patient that should go in there, because I might come up and say, you know what, I believe one thing so strongly, I'm not going to randomize that patient, okay? And infrequently, this gets thrown out. These are guidelines. They're to guide me. It doesn't truncate my beliefs. And so people would do things outside of guidelines, and I'll be the first one to be guilty of this, okay? So I'm going to end with this. An interventionalist, the thing that scares us the most is our stent going down. For a surgeon, the things that scare them the most is a bleeding complication. So those two things have to have sort of a balance of each other. And it's something sort of food for thought for all of us. And I do want everyone to think about your patient, think about these concepts that we talked about today, and hopefully you choose that best therapy for your patient. So I'm going to stop there to see if there are any questions.
That was a good 20 minutes worth we got there.
Yeah, all the high yield stuff.
Yeah, we got the summary points. That's the key. Very good overview of the guideline. Yeah, Derek invented an assay for platelet reactivity. He actually him and a cardiology fellow. The fellow became an AP guy, but they had his little junior fellow going for a little while.
So I'm just going to interrupt and say your mic is on, so make sure you're careful with what you say.
Hopefully they're compliments to me and not critiques.
Thanks, Derek. That was excellent. There's a question in the chat from Dr. Burwash. So I'm just going to read it out. So the non-STEMI patient is admitted to the ward from the ER at night. My experience is that they almost never get cathed in the next working day, but we don't know that that will be the case. Should the default be a dual antiplatelet therapy load?
Yeah, so I think if you don't know, I would say a safe assumption is that that patient will be going after 24 hours. So on a practical basis, I would do it. The patients where I wouldn't do it is, let's say if I see diffuse ST depression, AVR ST elevation, those ones I probably would think twice before bolusing. One of the things that you guys don't see because you're not nocturnal creatures usually is that at nighttime, the residents are very proactive. And that high-risk patients, if they're having ongoing chest pain, recurrent chest pain, they do call us. But same thing, right? If on the ward you feel strongly because you think this patient is very high risk in terms of further events, give us a call. We'll be able to try and get that patient in if we can, or we try and fit it in at the end of the day. But the answer is yes, I would from a practical standpoint. And keeping in mind, and this is why that Canadian perspective is different, let's say from Europe and the US. In Germany, a non-STEMI is treated as a STEMI. They get a non-STEMI within the cath lab within 6 hours at any given time. In the US, they've got centers with 18 cath labs, of which 50% are just sitting empty waiting for customers.
Question from Mohammed. Could you comment on duration of dual antiplatelet therapy for patients with high burden clots and history of stent thrombosis? He's asked about CAV too, but I think CAV is a completely different
So
creature.
I think there's several aspects of that, and all of us struggle, right? So that we've got that patient with lots of clot that's residual. We don't have a good answer in terms of what that therapy would be, right? Or patients have got that recurrent stent thrombosis. I think most of us in that stent thrombosis, if they come in multiple times, I actually would say that I would do long-term DAP as the best evidence. I would not usually throw in, let's say, a DOAC on that, okay? But I certainly hear that like, oh, there are lots of clot inside. I'm going to actually have triple therapy or dual pathway approach. There's no evidence for that, but people do it, okay? And then I'm not sure if he was also asking about LV clots. In that LV clot population, again, we do not have good evidence of, let's say, even warfarin over DOAC, but a lot of it comes back to convenience.
Do we have Canaglilor? Questions.
Cangrelor.
Cangrelor.
Yeah. So Cangrelor is an IV P2Y12 inhibitor. The reason why we stayed away from this on both iteration of guidelines is that initially it wasn't available. A drug company apparently is trying to push it right now. They actually approached pharmacy here and have been approached for discussions. It's very attractive in that you turn on that IV, platelets are immediately inhibited. You turn it off, 20 minutes later, P2Y12 effects are completely gone. Okay, so, and that's why a lot of this, let's even that surgical literature in the US, they'd say, screw it, right? I'm just going to start that patient on IV Cangrelor, go to the cath lab. If they've got a left main, I turn it off. 20 minutes later, it's ready for surgery. So we're hoping it's going to be available, but Canada is just not big enough a market for them to make money. And with government rules, they push down the price. So that's why a lot of companies have been shying away from offering these drugs in Canada.
So Derek, you talked about one of your favorite slides, the one with the circle and the red and the green.
Yeah.
Where the I guess it's the P2Y12 inhibitor is predominantly green as single therapy, and yet we have another image where extending your dual antiplatelet therapy for 3 years is suggested in a certain population with presumably low bleeding risk.
Yeah. So that's a great question.
How am I reconciling this? Like I struggle with this daily.
And I will tell you, I struggle with this, and I feel quite strongly, and I've been thinking about it for 2 years now, that someone has to apply a long strategy and do it in the North American population. The difficulty is this: if you go, let's say, by Ontario guidelines, after that 1 year mark, the ticagrelor is no longer covered unless you lie and put something else on your ODB. People do that, but in a study, really hard to do. Taking off that aspirin, right? Remember, aspirin's over the counter. The problem about designing that study is you don't know whether people are still taking the aspirin. And I talked to Sharon, who's got a placebo trial of aspirin versus a placebo in one of her groups. I calculated I'd be paying $3 million in creating aspirin placebos alone. And that's a very hard sell, but I think it's a great question. For sure, we don't know, because some would argue that the original predominant evidence of extending that in high-risk group is with dual antiplatelet therapies, but now there's P2Y12 alone. I think certainly that network meta-analysis sheds some light in terms of potentially that advantage. But like I told you, the only randomized trial, which is that host exam trial, was done in a Korean population. And I'll tell you, I personally am very bothered by this. So with my research, I've actually tested myself. I've got 2 copies of CYP219 in STAR2. I've taken a 600 milligram clopidogrel bolus just to test my platelet function machine. After 24 hours of therapy, 0% of my platelets are inhibited. So if I were that patient, I'd feel pretty uncomfortable going on clopidogrel alone after a 3-month duration of that. But for whatever reasons, they do it in Asia and nothing bad happens. So there is this South Asian paradox, and there are actually a whole series of paper written on that, right? But I think bringing that to generalizability, we do need a study. We're working on ideas in our post-PCI clinic. So it's coming. We're going to come up with a new strategy, and Mike Frosho will personally murder me when that new strategy comes up, because again, we each have our biases.
There's one last question from Dr. Shamoon. Before considering de-escalating, should we consult the interventionist? Only one criteria for complex PCI. I wonder what percentage of our patients have one criteria.
Yeah. That's why I showed that last slide, right? We are selfish beasts. When we have complex stenting, we're very possessive of those patients. So if I put a culotte stent in someone's left main, I probably want to call, because if you're going to stop that P2I12 or that DAP at 1 month, I think it warrants a discussion. But at the same time, that selfish beast aspect also works against us, right? That clearly, I think that when patients bleed and they come in the main hospital, now both drugs get stopped. That's when they have a stent thrombosis on top of that. So we have to be careful balancing that ischemic versus bleeding risk and giving us a call. So I personally, let's say if I did a left main and I've done an image guided left main, I know that that huge 4.0 stent is in that left main. I'm actually less concerned about that going down versus then a bifurcation in a mid LAD where there are multiple layers of stents there. So I think having a talk with us is very important.
Excellent. Thank you so much. Yes, I will be coming back for the genetic update in a couple of years. So we welcome you back. Thank you so much. That was very insightful and helpful. A reminder to everyone, there are not rounds next week. Next rounds will be at the beginning of May. Research Services should send out an invite for grand rounds. Thanks very much. Have a good week.